Assalamu alaikum. Today I have one very important topic that is the fracture along the proximal femur. So I included femoral head fracture and intracapsular fracture in this video. This is one of the common question you will be asked as a long question in your exam. And second thing is it is one of the common presentation in your clinical practice also. So it's equally important for your exam and in your clinical practice. So before starting, I just want you to know what are the part of the proximal femur. So this is head of the femur. This yellow one is the neck of the femur. This is greater trochanter. This is lesser trochanter. And the area between the greater and lesser trochanter is called as intertrochanteric area. And below the level of the lesser trochanter, in 5 centimeter, it is subtrochanteric area. So any fracture involving this fracture head of the femur, here if it is involved fracture neck of the femur, intertrochanteric fracture and subtrochanteric fracture. Out of that, for the exam, neck of femur fracture is very important, and intertrochanteric fracture is also very important. So these are repeatedly asked questions in your exam. So when you see the X-ray of the hip joint, we have the trabeculae. This is for the arrangement of the trabeculae along the distribution of weight. So we have few trabeculae starting from here, going like this. These are called as tension trabeculae. And we have few trabeculae going out like this. This is called as compression trabeculae because this is the compression side, this is the traction side. So traction trabeculae, compression trabeculae, and we have some trabeculae around the greater trochanter. It's called as trochanteric trabeculae. So we have among the compression principal primary compression trabeculae. Then we have the and partially that is secondary compression trabeculae. Same way we have primary tensile and secondary tensile. The last is at the greater trochanteric, that is greater trochanteric trabeculae. So if you see, this is the area we won't have any trabeculae in this. So this is the weakest point in the neck of the femur. This is called as Ward's triangle. Ward's triangle. So little about the development of the lower limb. So if you see, this is the front and the lower limb. So what happens is we have the structure on the medial side. This is we have the structures on the lateral side. This is what happens is during the course of development, the lower limb will rotate inside like this. So the limb which is facing anteriorly will face down. So this is rotation of the limb during the course of development. So what happens this during rotation is the structures which are present on the medial side will move posterior. Structures which are present on the lateral side will move anterior. So lateral vessels will become anterior, medial vessels will become posterior. So this is how it will be. If you see here, these are the lateral vessels, medial vessels, and this is the foot facing anteriorly. Now it rotated and foot is facing downwards. So the vessels which are lateral will become anterior, which are medial will become posterior. So this is about the little about the rotation and the development of the limb, which is relevant to the vascular supply of the proximal femur. So what is the why it is important? Because the neck of femur, the related complication of avascular necrosis and non-union. The main contributory factor for this two complication is the limited blood supply. So the head of the femur have very minimal blood supply from the obturator artery. Then anteriorly we have lateral circumflex. As I told, no, lateral circumflex was supposed to be here. During the course of rotation, it has moved anteriorly. Same way we have medial circumflex. So they give the branches which pierces the capsule and ascend into the head of the femur, and they form the subsynovial vascular ring. So whenever there is a fracture, there is loss of continuity of this vessels. So this is how the vascular supply of proximal femur is important. And we have few ligamentous attachments. So this is iliac and femur. So these are called as iliofemoral ligament. Same way we have ischium, then femur. So ischiofemoral ligament. So then we have pubis symphysis and pubic bone, the pubiofemoral ligament. So we have three important ligaments, that is iliofemoral ligament, ilium to the femur, pubiofemoral ligament, pubis to the femur, and ischium to the ischium to the femur, that is ischiofemoral ligament. So that give little stability or prevent the head going into external rotation or the hip joint moving into external rotation. So again, this is the same thing which I explained before, hip fractures. We can classify hip fracture into intracapsular, intertrochanteric, then individually lesser trochanter or greater trochanter involvement, or peritrochanteric. And lastly, subtrochanteric. So intracapsular includes head and neck. Along the neck, we can have just below the head, that is called as subcapital, or from this part of the neck to this part of the neck, that is called as transcervical, or base of the neck of the femur, that is called as basis cervical. So subcapital, transcervical, basis cervical. Then we can have intertrochanteric, lesser trochanteric, and just below the trochanter is a peritrochanteric, and within 5 centimeter of the lesser trochanter till the shaft, it is called as subtrochanteric. It is very high stress area. So we'll start with head of the femur fracture. So what is the head of the femur fracture? It's a very rare injury. It's a very rare injury. So, rare trauma usually associated with hip dislocation. So, it's a high impacted avulsion or shearing forces, mostly road traffic accident or sometimes fall from height and very high velocity sports injuries and industrial accidents. So, it is associated sometimes with isolated head of the femur or subcapital fracture. It may be having neck of the femur fracture and sometimes dislocation along with the acetabular injury. So it may associated with femoral neck, acetabular fracture, hip dislocation, and when there is a dislocation or high velocity injury, high risk of developing sciatic nerve involvement. So we need to take X-ray view. Sometimes X-ray is most not very contributory, or we may have the doubt in orientation of the fracture fragments, and we need to take CT scan. What is the treatment? If it is intrafoveal, very small fracture like this involving only this area, we can go for observation and rest. But large fragment, we can go for open reduction and internal fixation with the screw as shown in this diagram. Or if there is associated neck of the femur fracture, we need to think of either fixation or replacement of head of the femur. The complication of head of the femur fracture, the high risk of developing hip arthritis, there is non-union chances, avascular necrosis chances, and patient may land up sometimes in myositis ossificans. Now coming to very important topic, that is femoral neck fracture. So when in exam it is when it is asked intracapsular fracture, we need to include head and neck of femur fracture. Or when it is asked isolated neck of femur fracture, then we need to just write about this one. So this is a two different scenarios we may get in exam. I see intracapsular fracture means it include head and neck of femur. So which is what is neck of femur fracture? Fracture involving neck of femur, that is intracapsular part of the femur other than the head. So it happens with very high velocity injury if when it is in young patient, but just trivial fall or low energy falls in older patient. So what are the specificities of neck of femur? So one thing is every bone will have the two periosteal layer. One layer is called as cambium layer and the fibrous layer. So the cambium layer is this one which has nucleus and the osteoblast cells. The other one is the fibrous layer. So what happens is in the neck region, Cambium layer is not there. Cambium layer in neck not there. Only it has fibrous layer. So if cambium layer is not there, there is no osteoblast. So there is a poor regenerating capacity. So there is absence of cambium layers. And the second thing is, if you see, this is Estabulum, if there is a fracture here, you can't control the proximal fragment because it is having no muscle attachment. So the alignment will become difficult. Then third thing, as I told, the vessels pierce and enters in the retrograde manner. When there is a fracture here, there is loss of vascularity. So there is retrograde blood supply with the end arteries, which risks the head when it fracture or risks the neck when it fracture to a compromised vascularity. And in the joint, we have synovial fluid. These synovial fluid won't allow hematoma to form. When there is no hematoma formation, then there is no callus formation. So inadequate hematoma. And lastly, this whenever there is a bleeding inside, it increases the intracapsular pressure, which compresses the remnant vessels. So these are the few risk factors which risk the neck of femur going into compromised vascularity and increase the risk of developing avascular necrosis and non-union. So, what are the symptoms? What are the symptoms of fracture neck of femur? So, what are the symptoms? You can say the patient may complain pain along the groin region, and this pain is radiating towards the knees because of the nerve which is having the common supply to the head and neck and common supply to the neck knee. So sometimes patient only complains of pain in the knee joint. So we need to always look for the hip movements and hip tenderness when there is such complaints. Then there is a patient won't be able to bear the weight. So these are the few clinical presentations along with routine trauma injury. So we need to look for hip tenderness and hip is in partial external rotation. As I told no, this is the acetabulum, this is the head and neck. So we have iliofemoral ligament, pubofemoral ligament. So the fracture is happening proximal to this one. So when fracture is having proximal to these ligaments hold the distal fragment and won't allow it to go into external rotation. So here only I just want to clarify. Sometimes no, we have fracture involving intertrochanteric region. So intertrochanteric region is beyond the attachments of this pubofemoral and iliofemoral ligament. So it will go into complete external rotation. So if patient has hip injury, old patient with partial external rotation or complete external rotation. If it is only partial external rotation, it is neck of femur fracture. If it's complete internal external rotation, that is intertrochanteric fracture. This is how you can differentiate clinically by just seeing the patient on trolley, whether it is a complete intertrochanteric fracture or intracapsular fracture. How to take the X-ray? So traction and internal rotation. Why traction and internal rotation is very important? Because this is the neck of greater trochanter and the lesser trochanter. So if you see in the this one, this is the plane of the femur. This is the plane of the head. So it's around 15 degree of antiversion. When if you need to neutralize it, you need to rotate it down. When you rotate it down, the whole neck will appear like this. So it will give you very clear picture. So we need to take 15 degree of internal rotation and look for the Shenton's line. We need to take CT scan. If when you are doubt, bone scan. If still in the doubt, and MRI if we are thinking of some stress fracture or some other things. So how will you classify? The classification is very important. We have anatomical classification and Powell's classification. Anatomical is very easy. When the fracture is happening just below the head of the femur, subcapital, or in neck of in between the neck that is transcervical, or base of the neck that is called as basis cervical. subcapital, transcervical, cervical. And second thing, very important clinically when you are planning to do the surgery is Powell's classification. What is Powell's classification? If you see, these are your acetabular upper surfaces. So you draw a line along the acetabular upper surfaces. This is your neck, like this. And again, here also, this is your head, neck, like this. So when you draw a line along the upper surface of the acetabular surfaces, and same way you can draw, this is the fracture. You draw along the fracture like this. Or if patient is having fracture like this, you can draw the line like this. So this angle is called as Powell's angle. So if it is less than 30 degree, we classify it as 30. If this is less than 30 degree, it is type 1. 30 to 50 degree is 2. Type 3 is if it is more than 50 degree. So why it is important? So if you see, this is the thing. So if this is a fracture like this, it will remain like this, and the pressure will go into compression. So compression will stimulate the bone formation and union is high. The other option thing that happens is a oblique fracture. When there is high Powell's angle, when it try to compress each other, this will move this way, this will move this way. So this is called as shearing forces. So shearing forces are unwanted forces in fracture healing, which is whereas compression is what we need. So if we have compression, the fracture union will be there. If there is a shearing force, shearing force will not allow fracture to unite. So higher the Powell's angle, the shearing force is high. Then the last classification is Gardner's classification. It depends on the arrangement of trabeculae. So if the trabeculae is kinked, incomplete fracture. There is a complete fracture with aligned trabeculae, grade 2, 3, and 4, complete with full displacement of trabecular arrangement. Once you have diagnosed intracapsular fracture, you need to manage it. So the management of intracapsular fracture varies with age. So we classify according to age less than 5 years, 5 to 15 years, 15 to 65 years, and patient is coming more than 65 years with the neck fracture. If it is up to 5 years, we can put just go for reduction, either closed or open, and put pins. These are more spin or novel spin, and if need hip strike application. If patient is 5 to 15 years, we can fix it with this too. We can either go with closed reduction or open reduction depending on the pattern of the fracture and reduction. If patient is coming after 15 to 65 years, we need to again go for reduction. We can either use CC screw or we can use dynamic hip screw also. If patient is coming more than 65 years with the injury, so we need to examine whether patient is having arthritis of the hip or no arthritis of the hip. If patient is having arthritis of hip, we need to go for, if there is arthritis, we need to remove the acetabulum and head. So that is total hip replacement. If patient is having good hip, there is no arthritis, we can go for only replacement of head. That is called as semi-arthroplasty. So these are the prostheses we use when you are doing the arthroplasty. So here, why we use this one? When patient is having a neck or femur fracture plus no arthritis. Acetabulum is normal. So just we need to do is we need to just change the head. So how will you change the head? Either we use Thompson's prosthesis, we use Austrian prosthesis, or we can use bipolar. And the second thing is patient is having hip arthritis, where there is involvement of the head and acetabulum. We need to go for total hip replacement. That is, we need to replace the acetabulum along with the femur component. So total hip replacement when there is a fracture which is having additional arthritis. When there is no fracture with no arthritis, we can go for only hemiarthroplasty. Then what are the complications of intracapsular fracture? We have two very important complications, that is non-union and avascular necrosis. What is non-union? Non-union is the fracture fails to unite, but the vascularity is intact. Vascularity is intact, but fractures fail to unite. So why most of the time it happens is due to the shearing forces. This is going this way, this is going this way. So it won't allow to fracture to come together. So this is what happening here. This is going down, this is going up. So this is non-union. So what we need to do is we can change the shearing forces into compressive forces. How will you do that? We'll just cut the bone here, osteotomy, tilt it down, make it horizontal like this. So if you see the fracture is like this, after realignment, fracture has become like this. So now the forces are gone into compression forces. This osteotomy is called as Cowell's osteotomy because we are decreasing the Cowell's angle. Then avascular necrosis. Why avascular necrosis happens? Due to the compromised vascularity. So head of the femur loses vascularity and start going into necrosis. That's why it is called as avascular necrosis. So if the patient is having early avascular necrosis without like this in this patient, head is not disfigured, but there is loss of vascularity. In such cases, what we can do is we can do something to increase the vascularity. So we can put some muscle pedicle here, muscle pedicle graft, early avian. But if patient is having late avian with distorted head like this, then you need to go for total hip replacement. So if the we diagnose avascular necrosis at early stage where there is no distortion of head of the femur, we can go for salvage of the head by doing muscle pedicle graft. It goes by name Meyer's muscle pedicle graft. If patient is having late presentation with the arthritis and distortion of the head, then we need to go for total hip replacement. So we'll do a small exercise here. This is a patient with neck of femur fracture. As you see, the face is still little open, then he is around 17 years. More than 2 months of 2 months history of fracture. So in intracapsular fracture, if it is more than 3 weeks, we consider it as non-union. So if you see here, the density of bone looks okay. So there is no avascular necrosis. But here, if you see, this is your fracture line like this. If I try to draw a Powell's angle, this is the upper border of the sternum, and this is the fracture line. So this appears to be more than 50 degrees. So this patient is having very high Powell's angle. Very high Powell's angle means he is having shearing force. This is going down and this is going up. So there is high shearing forces. So for this patient, what we need to do? We need to we need to stabilize the fracture. Second thing is we need to decrease the angle. So how will you do that? So what we'll do is the patient is having the present situation is like this. So first we need to fix it. Then we need to cut here. So after cut, we need to tilt. So what we should do? We need to tilt it like this, so that the head will become like this. So this is how we need to fix it. So if you see this, this is very high angle. It has become horizontal. So let's see what we have done for this case. So here is a very high Powell's angle. We have fixed it with this DHS. Then osteotomy has been done here, and this has tilted down. The final X-ray, the Powell's angle has decreased abruptly. So it is less than 30 degrees. If it is less than 30 degrees, then it is stable fracture. So now the forces will go like this and give compression effect here, and the union chances is high. So thank you for listening to the topic. Uh, Please give your reviews and like the video. Thank you.